Oh, it was big. It was big. I couldn't carry it. Okay, so we're going to go ahead and get started. Hope you all had a good weekend. We're going to shift gears. So last week we did a series of topics in emergency medicine. This week we're going to shift to what I'll call it wilderness medicine, but there's a lot of overlap into what you might see in emergency medicine. Um, we have about 5 or 6 topics that we're going to do through the course of the week. Today, I think we'll start with heat and cold emergencies. I will say that this is typically a 2-hour presentation, so we'll probably cut it at about 1 hour. That'll walk us through most of the heat-related emergencies. I think being in Dominica, it's much more likely that you would be exposed to heat-related emergencies as compared to cold-related emergencies. But still, if we have time, we'll do a little bit of the overlap. And again, just like I said last week, if you have any questions, just flag me down and we can address those at the time. Okay, so there's a wide range of heat-related emergencies, and these are some of the topics that we're going to cover today. Some benign type of conditions like heat edema, heat rash, heat cramps, heat exhaustion, and then really a critical illness called heat stroke. So some things that are easily treated in an outpatient setting, all the way down to life-threatening conditions that you may encounter in your practice. So those will be the 5 heat-related emergencies that we're going to cover here. Also some medication or reactions that people will have to anesthesia or the psychotropic medications, which can cause some elevation in their body temperature, which we'll kind of address as well. So heat edema. This is something that's very common. It's very self-limited. Usually affects the feet, the ankles, and the hands. It's secondary to vasodilatation, orthostatic pooling. You'll see this often in the first couple of days when somebody goes into a hot environment. It's modulated by aldosterone and ADH in response to heat stress. The aldosterone will cause sodium retention and potassium wasting. I don't know if you guys have done the renal section yet, but your kidneys are very responsible for salt regulation and fluid regulation. Vasopressin or ADH, antidiuretic hormone, vasopressin, that's going to cause fluid retention. So that combination of sodium retention and fluid retention is going to give you some transient dependent edema. This is different than in elderly people that have congestive heart failure or may have a deep venous thrombosis that have unilateral swelling. Remember, generally in congestive heart failure, CHF, you're going to get bilateral lower extremity edema. We'll go over an edema scoring system as well versus a deep venous thrombosis, DVT. Usually that's going to be unilateral. There are conditions where you can have bilateral DVTs, bilateral venous thrombosis, and get bilateral edema, but that represents a very small percentage. And that's if you have somebody who has major pelvic vein thrombosis and it's affecting both of the lower extremities. So if you see somebody with bilateral leg edema, ankle edema, that's not related to heat, think much more congestive heart failure, right heart failure, causing pooling in the lower extremities. What's the number one cause of right heart failure? Left heart failure. Left heart failure is the most common cause of right heart failure. Other things that can cause right heart failure: pulmonary hypertension, COPD, massive pulmonary emboli can cause right heart failure. Also, patients with liver disease can present with ankle edema due to portal hypertension. Heat edema secondary to changes in temperature usually resolves in a few days, self-limited. You may tell people to cut down on their salt intake during those first couple of days. Leg elevation. Also, in older patients, you tell tell them that it's a little bit remember how the veins work. They have valves, right? What your muscle contractions are what pushes the fluid up back into your circulation. Muscle contractions have movement. In older people, it's those valves can sometimes be incompetent, or maybe they don't have that same brisk response. So support stockings, something we call TED stockings. If they wear them prophylactically when they first go into a heat environment, they can pretty much avoid this. Giving them Lasix or furosemide or diuretics is not going to fix this. This is time, leg elevation, support socks, and try and cut down on their salt intake. Fairly benign condition, nothing to really worry about, but somebody presents in a heat environment with unilateral after a plane flight to an area, think DVT. It's not necessarily. Yeah, so keep yourself well hydrated, number one, well hydrated. That will help with just your heat regulation, your body temperature regulation. We're going to talk about acclimatization. There's not a lot of ways around to avoid this. If you're going from a temperature zone to a very hot and humid area, this is going to happen. But again, it's self-limited. Give it 2 or 3 days, and it's gonna resolve. If you're going and you're going to be competing in a hot environment, let's say these ultra marathoners, et cetera, they usually get to these areas days in advance. It takes time to acclimatize. Acclimatizing to the heat, and we'll talk about that, usually 10 to 14 days, because your body shifts. Your body shifts its aldosterone and kidney regulation. Again, it's all salt and fluid management. Again, diuretics are not effective. I guess what you could do is you could use the support stocking, TED stockings. And for those of you that are going to be in a work environment when you're on your feet for 12 hours straight or something. Let's say you're working in an operating room and you're on your feet a lot, or me in the emergency department, we do 12-hour shifts. You're on your feet pretty much for 12 hours straight. Maybe you get a bathroom break. Maybe you get some time to go get something to eat real quick on the fly, but you're really standing on your feet. So I'll usually wear, kind of support socks if I'm going to be on my feet for 12 hours. Women who have had children are much more prone to having some venous pooling also. So certainly prophylactically wearing support socks are going to be helpful. Here's some examples of this. Just getting back to the grading of edema that we were talking about. Grade 0, obviously no clinical edema. This is going to be something, by the way, just kind of make a mental note on this. When you start doing your clinical rotations in your 3rd year, and you're on the internal medicine service, and you're going to see people with congestive heart failure, you're presenting the physical exam to your intern or your resident or your supervisor on rounds. It's good to be able to kind of share what some of these grading of edema. So for you to say they have ankle edema, I mean, if they have grade 1 ankle edema, that means something, versus grade 4, that means something completely different. So just roughly, grade 1 to grade 4 is progressive edema. Grade 1 is basically 2 millimeters of depth, which is pretty small. So when you compress on edema, you're going to leave a little thumbprint or a little indent there. The depth of the indent correlates with the degree of edema, and the rapidity with which that indent resolves also correlates with it. So grade 1, maybe only 2 millimeters, grade 2, 4 millimeters, grade 3, 6 millimeters. That's fairly deep. That's more than a half a centimeter. The extremity looks full, very visible, takes up to 30 seconds to rebound. And then grade 4, 8 millimeters, almost a centimeter deep, and it takes over 30 seconds to rebound. Something called anasarca. Anasarca is when you kind of got total body edema. This is usually somebody who does not have a lot of, they either have very significant congestive heart failure, or they have a very low protein in their body, low albumin, and it just causes leakage of fluid into the soft tissues. People who are in septic shock or in shock will sometimes be so sick that they will just leak fluid into the tissues and develop anasarca. We've seen patients who have, pitting edema up to their waist. They have significant scrotal edema. It can be very, very impressive. And it takes quite a bit of time with diuretics and treatments for that to resolve. And it can also be very uncomfortable for patients. You can also see patients with edema who get weeping edema. Weeping. They get vesicles and the skin is weeping, and it's moist. It wets their socks. It wets the sheet over them. They can get venous stasis changes in the skin. They can get a cellulitis secondary to this. So chronic edema is not only a cosmetic thing or a consequence of heart failure. It can cause a lot of skin dermal changes that can be uncomfortable, increase the risk of infection in the lower extremities. So edema, you need to be able to recognize it when you're doing your rounds with your senior attending or whatever. You have to be able to describe it somewhat cogently so that if you say edema, you say grade 3 edema, they can know what you're talking about. And by the way, once you've examined somebody and you've checked their edema, don't keep doing it. It's kind of uncomfortable for them. Sometimes, oh, wow, look at that. Let's do that again. Let's do that again. That's no bueno. Okay. That's uncomfortable for the people. Okay. So benign condition, heat edema. So heat rash, also commonly known as prickly heat, lichen tropicus and miliaria rubra, all the same thing. It's pruritic. Pruritic means itchy. Maculopapular is the type of rash that it is. Maculopapular is some of it's flat, some of it's raised. It's due to blockage of pores and macerated stratum corneum, which is a layer down in the skin. It's secondary to acute inflammation of the sweat ducts caused by blockage of pores on that macerated stratum corneum. The duct becomes dilated. You almost get little pustules under there. They rupture, causing vesicles in that layer of the skin. It's the predominant symptoms is a visible rash, and it's very, very itchy. You treat this with antihistamines, something like Benadryl or one of the other prescription antihistamines, cool compresses to soothe the irritated skin. You want to have the patient you don't want them to keep wearing wet clothing. You want them to ventilated, so try moisture wicking fabrics. You don't really put heavy creams on these kind of things that further occludes the skin. There's no real benefit for topical antihistamines either. So just oral antihistamine, cool compresses. Anytime you're having heat related things, hydration is going to be good. We'll talk a little bit about the best hydration drinks that you should be using, whether it's these sports drinks, plain water, or some homemade things that you can do. And obviously there's certain times where you're going to require intravenous hydration, but plenty of water, regular water is fine. It's good for your skin health. And it's going to help resolve this. You could probably get away with putting somebody on a little bit of topical steroids if it were very, very irritated, but most of the times you don't need to. And this is typically in the intertriginous area, skin folds, axilla, elbow, groin, behind the knee, popliteal fossa, where you're going to see this. A little bit of schematic is what we were talking about. You can see that sweat gland is somewhat inflamed. This is what that rash looks like. This is what's called a maculopapular rash. If you were to run your hand over this, it would feel a little bit bumpy. Versus none of these are really vesicles. Vesicles are those clear filled, almost like little bullae blisters, small blisters. This is more of a maculopapular rash. And this is what you would see with heat rash, and typically armpits, axilla, under the breasts, anywhere where there's pooling of some fluids and skin on skin. Heat edema, heat rash. Okay, so heat cramps, I'm sure probably if any of you have, you know, competed either in sports or we're out running or we're hiking or we're doing something for extended periods of time in the heat, you're susceptible for heat cramps. This is usually what you see on the, you know, football field in college football or basketball when they say somebody's got a cramp, they're down on the ground. This can be very, very painful, very, very painful. Um, and it's usually due to somewhat dehydration and electrolyte abnormalities. Um, affects the calves, the thighs, the shoulders. Sweating profusely without replacing it with a hypotonic. In other words, you're only drinking water, you're not getting your salt in. In the military, all military who are out in the field or in hot environments all have salt tablets that they carry with them. They don't recommend that you take salt tablets directly. They can be very irritating to the stomach, nausea and vomiting. So usually you need to dilute these with water. We'll show you a little bit of how much you put in if you were going to make this, or if you were carrying salt tablets. Let's say you were traveling into a hot environment, you would take salt tablets with you or some of these powdered electrolyte solutions, and how you would make those. Also, you can get these during exercise, or you can get it after you've been exercising. So sometimes you'll see people that have been hiking and they'll be resting and they'll this and that, and that's when the cramps will start coming in. You also get a lot of lactic acid that builds up in your muscles, so that can contribute to this as well. Again, the pain can be pretty severe. I don't know what we had done. I think I had done a Tough Mudder or something like that, and that night I had some cramps in my hamstrings that were so severe that I couldn't go to bed. I kept getting up trying to stretch, and it was really, really painful. And it was probably because of dehydration and I didn't adequately hydrate. Beer is a good hydration, by the way. It's a pain reliever, hydration, and you're getting some carbohydrates. Right. So if you're only drinking water, that's going to be hypotonic. So when we say tonicity, we mean consistent with the tonicity of your bloodstream. So isotonic is 0.9% sodium chloride. That's normal saline. That's what we give. Remember we said last week, if you wanted to hydrate somebody because they were either dehydrated or you wanted to replace their volume, you don't just give them sugar water. That's hypotonic. You give them normal saline, 0.9%. If you were getting dehydrated and you're sweating and you're losing sodium chloride in a heat environment, and I only give you water, that's okay in the beginning, but the more you sweat, the more sodium. All I'm doing is driving you're spilling sodium, right? So your sodium's dropping, your total body sodium's dropping. I'm replacing it with free water, and that can lead to hyponatremia in the body and other electrolyte abnormalities. And again, the pain is very severe. It's not only due to sodium, it's other electrolytes, magnesium, other electrolytes that can become you can get very painful. This needs to be differentiated from rhabdomyolysis. You know what rhabdomyolysis is? That's when your muscle cells essentially break down and release the myoglobin into your bloodstream. If you have rhabdomyolysis, the muscles are swollen, they're painful. It's not a brief self-limited thing, it's actually progressive. Spilling all of that myoglobin into your bloodstream, what are we at risk for with excessive myoglobin in the blood? Kidney failure. Essentially, the renal tubules get occluded with all of this myoglobin in your bloodstream. What does your urine look like if you have myoglobin from excessive muscle breakdown? What color will your urine look like? It'll be red, maroon, brown, almost like Coca-Cola, okay? That's the globin. That's the globin from the myoglobin that's coming out through the kidneys. So if you see somebody that is complaining of, usually it's the larger muscles of the body, the gluteus, the thighs, the big muscle groups is where you usually will get rhabdomyolysis. And those patients, if their urine color is maroon, red, purplish, or this or that, that's a serious consideration. Normal CPK, creatinine phosphokinase, in the body, which is a marker of muscle breakdown, is going to be about maybe 0 to 200, let's say, in the bloodstream. You see people with significant rhabdomyolysis up in the 80,000, 100,000. So exponentially large amounts of myoglobin in the bloodstream. This creatinine phosphokinase and myoglobin are very similar. One of the poor man's tests, if you don't have a extensive lab testing and all you have is a microscope, if you take a little dipstick and you see this dark urine, you put a dipstick in there and it shows that there's blood in there, it'll show globin in there, and then you were to look under the microscope, you would see no red blood cells. That means it's myoglobin, not hemoglobin. You, like I said, also with these heat cramps, hypochloremia, hyponatremia. Hyponatremia is a low sodium. Hypochloremia is a low chloride. And both of those from excessive loss of sodium chloride and only replacing it with hypotonic solutions. So how do we treat this? You want to replace the fluid and you want to replace the salt. You can either give it PO, per oral, that's oral hydration. PO is by mouth or per oral, and IV means intravenous. If you're giving it by mouth, you cannot tolerate an isotonic solution. You can't really tolerate a 0.9. That's like drinking salt water. It's going to make you very nauseous, very uncomfortable. Most people can't really tolerate that. So you want to drink a fluid that is about 0.1% to 0.2% saline by mouth. So what you can do is salt tablets contain 10 grain or 630 milligrams of sodium chloride. If you take 2 of those and you put them in 1 quart of water, that will produce 0.1%. So if you're going to be doing some backpacking or you're going to be doing some hiking in a hot environment, I would recommend, and we should probably, I think I have a list here, things that you should bring when you're going on an expedition. But salt tablets or hydration salts would be something that you would want to bring with you. It's also good if you get a diarrheal illness while you're traveling that you have replacement salts. So that should be in your travel kit, some type of replacement salts. It can be simply salt tablets, these 10 grain salt tablets, or you can get these powdered electrolyte solutions. So Gatorade, let's just compare some of the market kind of available things. Gatorade is an electrolyte solution. It was invented at the University of Florida, hence the name Gatorade. And that has 270 milligrams of sodium in a 20-ounce bottle, which equates to 0.034%. So only about a third of what you would get as it pertains to 0.1% of the homemade solution. I will say this, though, for hydration purposes, electrolyte solutions that contain carbohydrates are absorbed 30% faster. I don't know why that is. Something about having the carbs in there causes you to absorb that faster. So unless you're really, really sodium depleted, the Gatorade is fine. I would recommend that regular Gatorade is probably too much sugar. So even maybe a little bit of a diluted, or that there's a Gatorade Zero or something like that that has less carbohydrates in it. Pedialyte, which is what we give to little kids that come in with vomiting and diarrhea, that's 370 milligrams of sodium in 12 ounce, which is about twice as much sodium as it is in Gatorade. So that's 0.078%, but that's still not the same amount as that 0.1% by just putting 2 salt tablets in a quart of water. And it's a lot cheaper and easier to carry just a thing of salt tablets. Say again? Yeah, so you require the sodium because remember what's in your perspiration? Sodium chloride. Cystic fibrosis, what do? They do a chloride test of the skin because they have an abnormal wasting of chloride. So you're replacing that. Some of these other electrolyte solutions, these powder ones, also contain magnesium and other types of solutions, but typically it's going to be sodium chloride that you're going to be replacing. Does that answer your question? Okay. If somebody who's got severe symptoms of heat cramps, IV hydration, when you see these ultra marathoners that there's some of these races where they'll do the seven deserts or one desert on each continent and they'll run. Usually they have hydration stations periodically along the way where they'll get intravenous fluids. When we are rehabbing firefighters who come out of a fire, they'll go into the tent. We'll usually give them 1 or 2 liters of normal saline to quickly rehydrate them. So you can prevent this by maintaining adequate dietary salt, these commercial electrolyte solutions. The salt tablets alone, like I said, are a gastric irritant and can cause nausea and vomiting. So you want to have these properly dissolved first. Heat tetany. What is tetany? That's a severe contraction of the muscles, and there's some classic forms of this. For those patients who are hyperventilating, I don't know if you've done this yet, if you've done this pulmonary medicine yet, but hyperventilation is going to drive down your CO2, right? You're blowing off your CO2. You're blowing off your CO2. That's going to change the pH of your blood, and your blood is going to become alkalotic. That's called respiratory alkalosis. This is the person that you get a blood gas on them, an arterial blood gas, and their PCO2 in their blood gas, which should be maybe about 40, is somewhere 32, 30, 28, and their pH is like, instead of 7.4, which it should be, 7.5. So they're respiratory alkalosis. Your body tries to compensate by creating a metabolic acidosis to bring that pH down, but this is usually very fast from hyperventilation. And what does that do? It drives calcium into the cells. Remember, you're trying to create a metabolic acidosis. How do you create acid? You put hydrogen ions in there, right? Hydrogen chloride. So hydrogen will leave the intracellular space, and it has to be an exchange. So hydrogen comes out, calcium goes in, and that's going to decrease the circulating calcium. And that will cause paresthesias in the fingertips, the toes, and around the mouth, perioral or circumoral paresthesia, carpal pedal spasm. You'll see patients that are hyperventilating. They'll come in like this. It's causing carpal pedal spasm, carpal, or pedal, and they'll get the feet like this, very uncomfortable like this. It's classic when you see somebody come in who's hyperventilating either from an anxiety attack or some type of other, other cause. Usually it's hyperventilation, but let's say they had some type of condition that caused them to increase their respiratory rate out of fright or flight or something like that. They were breathing very rapidly. It's going to cause this carpal pedal spasm. This is different from heat cramps because this doesn't really have pain associated, and it's very specific, the areas of the body, due to this hypocalcemia. The paresthesia, the perioral. So this will be the person who comes into the emergency room. They're scared. They're breathing very fast. Their hands are like this. They're saying, I feel numb. I feel like I'm going to pass out. They're very frightened. You try and calm them. Some people will say, you breathe into the brown paper bag. Not too good to do that for too long because you can actually drop their oxygen level unless if they're not doing it properly. So we'll sometimes put them on a non-rebreather mask, low flow oxygen, have them kind of rebreathe some of that CO2 because they're blowing out CO2. You actually want them to take some of that back in. So you want to try and remove them from the heat, decrease the respiratory rate through a calming environment and coaching and reinsurance. When you're breathing fast also, you're blowing off hot air. This is one of the ways that we cool somebody that has severe hyperthermia. We'll intubate them and we'll give them cool air to help cool them off. But when you're blowing out, you're relieving heat. This is how dogs and animals cool themselves by panting very quickly and breathing out that hot air. They're actually cooling themselves. This is a schematic of carpal pedal spasm, like this. Very classic when you see it. And the same thing with the pedal. You'll see the wrists are flexed, the fingers extended, the thumbs adducted. Remember, add towards the body. Remember that? Abduction moves away. Adduction, you're adding it to your core. Just figure out some way to remember that because it gets a little bit confusing. There's another condition called Trousseau's sign. Trousseau's sign. There's Trousseau syndrome. Trousseau's sign is if you were to put a blood pressure cuff around someone's arm for a tourniquet, or you put a tourniquet around someone's arm, if you leave that on long enough, it's going to cause that same carpal pedal spasm because that blood pressure cuff is going to be over the systolic pressure. It's going to cause that calcium to drop. Because you're going to get acidotic in that area, like hydrogen's going to be leaving, calcium's going to be going in. You get some local hypocalcemia, and you'll get this carpal pedal spasm. I had a lady one time. She had a degloving injury of her finger. She had a ring on her finger, and she was walking her dog, and the dog chased. The leash caught her ring, and it tore the ring off her finger, and along with that, it pulled the dorsal side of the skin off. So fortunately for her, there was no tendon injuries, no bony injuries. So it was really a matter of just kind of taking that peeled and degloved skin and kind of debriding it or cleaning up the edges and putting it back on. But there was a lot of bleeding. So I put a tourniquet around, I don't know if I put it on her forearm or up here to control the bleeding. It was too low down to just put a tourniquet around the base of the finger. And the procedure probably took me about 30 minutes to approximate all the wound margins and debris. And by the time I was done with that, the lady developed this Trousseau sign, and she started developing carpal spasm on the one hand. And as soon as I took the tourniquet off, it improved, and she was able to, and that was relieved. There's something called Trousseau syndrome, just as a sidebar thing. This is a migratory thrombophlebitis associated with pancreatic cancer. That's completely different. So Trousseau syndrome versus Trousseau sign. And this is normal. This Trousseau sign is normal. It can happen to anybody, but it can be consistent with hypothyroidism, vitamin D, kidney failure, pancreatitis, which can cause hypocalcemia. But if I took a normal person and put a tourniquet around, they're going to develop that also. Okay, so we're getting to a little bit more severe kind of things now with regard to the heat. So heat syncope. What does the word syncope mean? Passing out, blacking out, syncope. It's usually caused by postural, standing up hypotension. A lot of medications can cause postural hypotension. So Antihypertensive, blood pressure medicine cause it. Some of the medications used for BPH, benign prostatic hypertrophy, Flomax, some of these things that help with urinary conditions can also cause hypotension. Some of the antidepressants can cause postural hypotension. So whenever you're starting new medications that are associated with postural hypotension, good to have them maybe start low doses and maybe even take it in the evening. They're going to be laying down at night until their body kind of gets used to the medication. But starting a new medication that causes postural hypotension and then exposing them to heat, exposing the heat is going to make it. Why does heat or hot environment increase the risk of syncope? It causes peripheral vasodilatation. So blood goes to the periphery, to the skin. Think of your skin as a radiator. If it sends the blood to your skin, it's going to try and cool. If your core temperature is going up, your body says, "Okay, I got to cool myself down. Let me send the blood to my periphery, to my superficial skin as kind of like a radiator." This is how elephants cool themselves, by flapping their ears. They have a lot of circulation into their ears, and it helps cool them. So when you see an elephant doing this with its ears, it's cooling itself, or it's about to charge you, one or the other. So you take volume depletion, you have peripheral vasodilatation, and you're going to lose some of that vasomotor tone in your periphery. That's going to lower your blood pressure. Particularly in a non-acclimatized individuals, they might be a little bit dehydrated. So you remove from heat, hydrate, rest. But syncope, passing out, postural syncope, heat syncope, in an elderly person can be dangerous. A lot of these people are on anticoagulants because of atrial fibrillation. They're on Plavix, antiplatelet medications. They pass out, they hit their head. As you get older, the bridging veins in your brain, as your brain shrinks, your skull doesn't, so you get more space between your brain and the internal cavity of your skull. So these bridging veins have a little more stress. So young, healthy people like you fall, hit your head, no biggie. Older people fall, hit their head, those bridging veins, the brain shakes around a little bit in there, tears those veins, and it gives you what's called a subdural hematoma. You add the fact that they're on an anticoagulant, and that's a very bad combination with a very high mortality. Differentiated from an epidural hematoma, which is a high pressure arterial bleed, usually from the one of the temporal arteries or a skull fracture. You also want to make sure there's not other causes of syncope. We were on Linda and I, my wife Linda and I were on a mission trip, and there was a gentleman who had a syncopal episode, and everybody thought maybe he just had a vagal episode, this and that. Fell, hit his head, had a skull fracture, an intracranial hemorrhage. It was a real traumatic kind of thing. He was one of the workers on this medical mission. Spent a couple of weeks in the ICU, and they're addressing his intracranial hemorrhage, and it turned out the reason for his syncope was cardiac syncope. He ended up getting a pacemaker because during the course of his observation in the ICU, they saw that he was having significant cardiac arrhythmias. So it's okay to blame it on heat syncope in the right clinical setting. But in older people or people with structural heart disease or arrhythmias, you need to make sure that it wasn't an arrhythmia that caused that person to pass out. So don't just assume. Remember we said last week, tunnel vision. If you focus on one diagnosis and you don't think about other potential things, maybe that'll work out for you most of the time, because most of the time that common thing happens, but you're going to miss it other times by just assuming that it's that one thing that caused it. Okay, we talked about acclimatization here. Generally, it's a 10 to 14 day process. You adapt to warmer, more humid environments. via hypothalamic and thyroid adaptation. It's mediated by aldosterone, decreased sodium concentration in the sweat and urine to preserve fluid volume. You have earlier onset of sweating and greater sweat volume. Linda and I went to Mass the other day in Portsmouth, and I was dressed about like this, and I was sweating like a pig. And I've only been I've been here only less than a week. So I have not yet fully acclimatized. So day 10, I think, is maybe this Wednesday for me. So I'm hoping I'll be doing a lot better. But I looked around the church, and there were people that had long sleeve shirts on and, long pants. They were dry as could be. I had sweat under my boobs, my shirt was stained. I felt terrible. I'm dripping. And so I haven't properly acclimatized. Next time I'll wear shorts, I think. Okay. So due to inadequate acclimatization, you're much more prone to heat exhaustion. These are the ones where you see somebody who they're working out in some kind of sporting environment and they're just depleted with water and salt, and they can't even get up off the ground. They haven't passed out. They're just profoundly weak. Also, maybe they're hyperventilating because they just feel so typical. So this is water depletion, salt depletion, or some combination. More typical in the elderly, hot environment, inadequate fluid replacement. You'll sometimes see this in people that older people live in their home. It's a heat wave happening. They're not adequately hydrating. By the way, as you get older, that reflex to drink water is not as good as it used to be. Psychiatric medications blunt your thirst reflex sometimes. Other medications can blunt that. You don't really feel thirsty until you're about 5% dehydrated. Your body's a little sluggish in sending that message. Hey, drink water, drink. You don't really start to feel the need for thirst until you're about 5% dehydrated. By then, it can be a vicious cycle because you can go from 5% to 10% dehydrated fairly quickly in an outdoor heat environment. Salt depletion, fluid depletion in an unclimatized person. These are the people that have headache, nausea, vomiting, just so weak. They're dizzy, muscle cramps, tachycardia, hypotension, all the things you would expect with clinical dehydration. Their temperature is probably normal or mildly elevated, certainly less than 104. 104 is the cutoff for heat stroke. We'll talk about that. And the typical thing with this is there's no neurologic abnormalities. They don't have ataxia. They'll feel dizzy, but they're not confused. They don't have an altered mental status. Ataxia meaning loss of balance. The cerebellum is very sensitive to heat. Cerebellum controls your gait, a lot of your balance. So in patients who have heat stroke, which we'll get to in a second or two, those are the ones that are going to have altered mental status and ataxia being a common early sign. So symptoms are headache, nausea, vomiting, malaise, dizziness. Malaise just means a feeling of no strength. Dizziness, muscle cramps, dehydration, tachycardia, and hypotension. Remember, normal heart rate, 60 to 100, tachycardia over 100, normal blood pressure. Anything under 100 is hypotensive to me, unless somebody normally has a low blood pressure. If you were to draw blood tests on people that came out of a heat environment like this, hemoconcentration. What is hemoconcentration? Normally you do a blood count and you check their hemoglobin and hematocrit. Normal hemoglobin and hematocrit is between a hemoglobin of 12 to 15 is essentially normal. Hematocrit between 40 and 45. People who are dehydrated, they've lost intravascular fluid volume. You do a blood count on them, their hemoglobin may come out as 16 or 17. It doesn't mean they have polycythemia. It means that they're just hemoconcentrated. So if you ever test some blood on somebody who maybe is somewhat dehydrated, they have a very high hemoglobin, After they're hydrated, you should recheck that because it's probably going to normalize. Again, if you're not taking any fluid, so if you're volume depleted and you haven't been sweating out your sodium or peeing out your sodium's going to increase in your intravascular space. Normal sodium's from, I don't know, 135 to 150. Sometimes you'll see these people. Typically, you see this in people with type 2 diabetes, hyperosmolar coma. They'll come in and their sodium will be 155, 160, 165 with a glucose of 800. Why? Because the glucose is causing this osmotic diuresis through their urine. They're pissing out water and sugar and getting dehydrated just with water loss, and they're holding on to their sodium because their kidneys are trying to hold on to the sodium, and your sodium's going to overshoot 155, 160. You're going to replace this with volume and electrolytes. Again, oral versus IV, depending on what the labs look like. You're going to remove them from the heat, and you're probably going to want to put them in a cool environment. That's passive cooling, just by putting them in a cool environment. Active cooling we'll talk about with people that have heat stroke. This can progress to heat stroke if the temperature keeps going up. So if you haven't had the temperature start to come down after about 30 minutes of hydration, fluid replacement, and removal from the heat, then you need to really aggressively cool them. And we'll show you what some of those techniques are. So heat stroke. Heat stroke is a life-threatening condition. Very high mortality if left untreated. These are the patients that present with hyperthermia, a temperature over 104 Fahrenheit or greater than 40 degrees centigrade. They also present with altered mental status, either confusion or some other type of neurologic deficit. Anhidrosis in about 50%. Anhidrosis means they're not sweating. They lost their ability to sweat. Why? Because they've probably already been sweating and they've now depleted that, and they are now anhydrotic, about 50% of them. So they'll actually come in with dry skin and a temperature of 105. The central nervous system is particularly vulnerable, with the cerebellum being highly sensitive. So that's where you get the altered mental status and the ataxia. Ataxia is usually the earliest sign of cerebellar dysfunction, irritability, confusion, bizarre behavior. Again, you see this in some of the people who are maybe on some methamphetamines or other drugs that are going to give them high fever. It's going to give them some of their bizarre behavior because they come in sometimes with temperatures of 105, 106, inadequate fluid intake, high temperature, lots of motor activity driving that temperature up, combative hallucinations. They can present in a coma. They can present with a seizure. Status epilepticus means seizures that don't usually seizures are self-limited. They resolve in, I don't know, 1 to 5 minutes. Seizures resolve. Febrile seizures in kids, little kids with high temperatures who have febrile seizures, they usually self-limited. They resolve usually in, I don't know, 2 to 3 minutes. They're very frightening for the parents of a small child, but they're self-limited. Status epilepticus, this is the person who's been seizing for 20 or 30 minutes. That's not good. That's not good. It's not good for the brain. You're frying brain cells with that. Neurologic injury correlates with the height of the temperature and how long it's high. That's why you need to cool these people off quickly. So if you're out in a heated environment and you have somebody who's, they stop sweating, their skin is hot as can be, and they're confused, they're ataxic, that's a medical emergency. You need to remove them from the heat, start active cooling, hydrate them as best as possible. People with altered mental status, you got to be careful with oral hydration too, because it's going to maybe affect their gag reflex. Maybe they're very somnolent. They're not going to be able to handle oral hydration well. So that's why you got to recognize this early on before it progresses to seizures and coma, because then you can't really orally hydrate them. So there's two types of heat stroke. There's exertional heat stroke. This is the young athlete out on the football field during two-a-days, or the marathon runner, what have you. Those are the ones that exert themselves, causing their due to muscle activity in a hot environment, and their temperature is going to go up. You can still cool your body up to a certain point through evaporative cooling. That's the normal way that we cool ourselves, evaporative cooling. But if you're in a temperature over 90 degrees, over 85% humidity, and you're sweating, but it's not evaporating, you're really not cooling yourself. You're just losing fluid. So over 90 degrees temperature, over 85% humidity, ineffective evaporative cooling. Ineffective. And those are the situations where you can get exertional heat stroke versus classic heat stroke, which is non-exertional. That's the little old lady or the little old man who's in their apartment during a heat wave in Southwest USA or somewhere where it's very, very hot, 110, 115 degrees. Their window, they don't have air conditioning. They're inside. They're not properly hydrating. Remember, I said some of the medications and age interfere with your thirst drive, magnified as you get older if you're on medications. These are the ones that are found in their apartment because their newspapers are piling up outside with temperatures of 105, 106. Very, very bad prognosis. Immediate cooling is indicated with support of your organ system. Any delay is going to increase their mortality. There's no specific diagnostic test other than taking a temperature and looking for altered mental status or CNS complaints. So this is one: history and clinical presentation. Labs may detect end organ damage, renal failure, liver disease. These are some of the tests if you're able to get somebody to help: complete blood count, comprehensive metabolic panel, arterial blood gas, coagulation studies. A lot of these people have coagulopathies and bleeding disorders. A CK, a myoglobin, looking for rhabdomyolysis, urinalysis, EKG, looking for dysrhythmias secondary to electrolyte abnormalities, chest X-ray, lumbar puncture, CT, because of altered mental status and high fever. That's also what you get with meningitis: high fever, altered mental status. So if the history's not there, you got to look further, either with a spinal tap or a CT of the head. Anybody that ever presents with focal neurologic findings, they have weakness in one arm. Let's say they have a fever, weakness in one arm, focal neurologic symptoms, seizure. Before you do a spinal tap on that person looking for bacterial meningitis, you need to scan their head to make sure they don't have an abscess or some other space-occupying lesion causing those focal findings. Also, lactic acidosis and hypoglycemia. We're almost done. So non-exertional. This is the 82-year-old female with a history of hypertension, previous MI, brought in by her family because of confusion, found her in her house with the windows shut, very hot, lying in her bed in the morning, rectal temp 104.8. By the way, little pet peeve, pulse of 124. You feel somebody and they feel hot, and they came in through triage and somebody did an ear temperature and it says 99, but you feel them. Their face is red, they feel hot. Rectal temperature is the way to go. People don't, people get a little freaky with that, but I had a doc I used to work with, great doc. He would ask the nurses to always do a rectal temperature if he had any suspicion. My own personal practice was if somebody had it felt warm to me, and I read the triage note and it's a temperature of 97.6. It just didn't make sense. I would take their oral temperature myself. Still didn't make sense. Then we do a rectal temperature. You change probes, by the way. Yeah. So that's non-exertional classic heat stroke. Exertional heat stroke, again, this is a 26-year-old healthy British cricket player, fell to the ground and vomited during a game, brought to the sidelines, vomited again, more and more confused, then had a seizure. young, sweaty. Remember, they may not be sweaty, unresponsive, pulse of 148, low blood pressure, rectal temp, won't give a reading. Sometimes these thermometers, these digital thermometers, only go up to a certain amount, 105. So not giving a reading means it was probably even hotter than that. There's other special thermometers that you can get that will go higher and lower, but your average thermometer has a range. They won't go below, let's say, 94, and they won't go above 104 or 105. It's just the limitations of some of these digital thermometers. A true glass thermometer obviously is going to have a wider range, and there's other type of probes that you can monitor even lower. So for people that come in with severe hypothermia, their temperature is 82 degrees Fahrenheit, you need special thermometers for that. So those are the two different types of heat stroke. They still need to be managed aggressively. Some of the differential diagnoses, whether it be infection that you see on the left there, drugs or toxins. We'll talk about a couple of those in a second. Hypothalamic dysfunction. People who have had anoxic brain injury who are in the ICU on a ventilator, they'll often be running high fevers, remitting fevers, and they'll be thinking, oh, is this an infection? Is their central line infected? You got to make sure there's not an infection, but it could just be due to hypothalamic dysfunction from anoxic brain injury. Obviously, environmental conditions. Thyroid storm, hyperthyroidism can cause an elevated temperature, pheochromocytoma, diabetic ketoacidosis, lymphoma, leukemia. So you can see that there's a lot of things that can cause very elevated temperatures. So that's where a good history and clinical examination is really, really important. Anticholinergic toxidrome, we'll just talk about this for a second. This is the one where you are mad as a hatter, dry as a bone, red as a beet, blind as a bat. This is usually due to some type of anticholinergic medication, cyclic antidepressants, atropine, scopolamine. Scopolamine are those seasickness patches that people would put on. I've seen people that have been on a cruise ship and be putting these things on. And what you're supposed to do is when you put a new one on, take the old one off. I've seen this with nitro patches, with fentanyl patches. People just keep adding more of them. They don't take the old ones off, and they can actually get very symptomatic. Nitro patches, low blood pressure. Scopolamine patches, they can come in with anticholinergic syndrome. Excessive antihistamine overdose. Somebody wants to kill themselves and they take, 500 milligrams of Benadryl. They're going to present with anticholinergic symptoms. Even over-the-counter stuff, Jimson weed can cause this. Treatment is GI decontamination with either activated charcoal if it's soon enough after the ingestion. You sedate them with benzodiazepines. They can have a wide complex arrhythmia, which you're going to treat with sodium bicarb. And you can also give them physostigmine because these patients come in, again, high temperature, hot as a desert, mad as a hatter, mental status changes, dry as a bone, they're not sweating, their face is red, dilated pupils, blind as a bat. So it's pretty pathognomonic. They used to see this in people that worked in the hatting industry when they used mercury for the felt that was in hats. That's where it got the name mad as a hatter, because those people would come in with mercury toxicity, which would cause a anticholinergic syndrome. Another cause of a very high temperature can be, again, medication cause, malignant hyperthermia, life-threatening clinical syndrome, hypermetabolism involving the skeletal muscle, lots and lots of motor activity, abnormal receptors control calcium release, causing a buildup of calcium in the skeletal muscle. Drugs that can cause this, succinylcholine. This is a paralytic agent that we use when we're doing rapid sequence intubation. It's one of the most common causes of malignant hyperthermia. Halothane inhaled anesthetics, the fluorines can cause it, phenothiazines, and ether. This is why when you go to have surgery and you're going to receive any anesthesia, you get asked about 10 times, have you ever had a problem with anesthesia? Has anybody in your family ever had a problem with anesthesia? You can't really predict who's going to get this. It is genetically related. So if you have a family history of it, anesthesiologists need to know that, and they may use some other medications, maybe a propofol instead of some of these other medications. Treatment is with dantrolene, cooling blanket. Complications, rhabdomyolysis because of the skeletal muscle. Compartment syndrome. What's compartment syndrome? Muscles in the arms, usually your forearms, and in the calves can get so swollen. They're in these compartments. They cause the swelling that increases the pressure in the compartment becomes greater than the arterial perfusion pressure. So you get distal ischemia, inadequate blood flow because of high pressure in these compartments. These are the patients, either burn patients, trauma patients, crush injury, where they end up with a fasciotomy. You have to open up that compartment to relieve the pressure. Otherwise, you can lose circulation distal to that. Prevention, good family history, avoid stimulant drugs. But most common cause is succinylcholine. I've personally never, through my years of intubating patients in the ED, I love succinylcholine. It's quick onset of action, usually 30 to 60 seconds. You give it, patients, they have no motor activity, little bit of fasciculations, and then it's off of them in about 5 to 6 minutes. It's great because it relaxes all the muscles in the upper airway. It makes intubation a lot easier. If you're ever giving anybody succinylcholine, though, you need to sedate them. Could you imagine? I mean, this is kind of what would be in like those dart guns where you're paralyzing somebody. They don't breathe. It's very frightening. So if you're giving somebody a paralytic agent, you need to sedate them also. That's why you usually pre-medicate them with a sedative agent, and then you give them the succinylcholine. There's serotonin syndrome, which is very acute within a matter of hours, versus neuroleptic malignant syndrome. These are two other conditions that can cause very high fever. You can see the serotonin caused by SSRIs, tricyclic antidepressants, some synthetic opioids, other illicit drugs, hyperreflexia, clonus, which is if I go to stretch your arm out, it causes these contractures like that. That's clonus. Other GI symptomatology, serotonin syndrome from excess serotonin in the body, neuroleptic malignant syndrome, gradual days, weeks. Again, antipsychotics. If you suddenly stop dopaminergic agents like levodopa, that can cause that. So remember, medications can cause elevated temperatures. So these were the things we talked about there for heat stroke, hyperthermia, altered mental status, some of the other additional signs and symptoms you may see there, anhidrosis in about 50%, visual disturbances, fatigue, weakness, all the way down to coma. A little schematic showing the differences between heat exhaustion and heat stroke. Again, the hallmark is how high is the temperature and whether they have altered mental status. Heat exhaustion should not have altered mental status. Again, heat exhaustion can progress to heat stroke if you don't address the situation quickly. Let's get to cooling techniques real quick here. Evaporative cooling, cheapest thing to do. You take a little squirt bottle, you get somebody on the stretcher, you spray them with the cool mist, and you run a fan over them. That's the fastest way to cool somebody. Immersive cooling is putting somebody in a homemade little ice bath. It's kind of hard if you're monitoring patients to submerge them in an ice bath. You can also just put ice packs to their neck, the axilla, axilla and the groin, places where there's a lot of blood flow, ice packs to those areas. Um, Cooling blankets, it's kind of like it's an air blanket that goes over them or something that goes underneath them that controls their temperature. We do this in out of hospital cardiac arrest with return of spontaneous circulation. We want to cool them for the first 24 hours or at least stabilize their temperature. So we'll use cooling blankets. In severe cases, you can put them on cardiopulmonary bypass or ECMO. You can also drop an NG tube, lavage them with cold water. You can put a Foley catheter in there, lavage with cold saline, rectal or peritoneal lavage. So a lot of extreme things. I think evaporative cooling is probably the easiest, readily available, and most effective. Immersive cooling is not practical because of immersing somebody in an ice water bath. These other ones also can be used, but there's usually some barrier to doing that easily. This is kind of pretty much everything we talked about. In the ER or in these field medicine things where you're dealing with this, you usually have a cooler with cool saline in there that you'll give to, that you'll keep available. Refrigerated crystalloid. Surface cooling, you want to remove all of their clothing, spray them down and get a fan or just fan them. Evaporative cooling, again, is probably the most effective early on. It's just a schematic showing location of the ice packs, elevating the feet to kind of get the pooling of the blood in the legs back into the circulation for cooling. You can wet the body and clothes with a fan over them. Very easy to do. Even if you don't have a fan, you can just have somebody fanning them with manually. You can have long-term neurologic complications. Again, we talked about rhabdomyolysis, renal failure, liver failure, myocardial muscle damage, coagulopathies. People that need to be admitted to the hospital, usually those with heat stroke or heat exhaustion or heat that hasn't resolved. But heat stroke usually end up in the ICU. Elderly people and young. Remember I said this last week, extremes of age don't have the ability to compensate as well. So under the age of 4, over 65, 70, 75, the compensation mechanisms aren't as good. Young, healthy people usually do pretty well. People who are boozing are sometimes going to have problems with that. You admit somebody who was maybe found sleeping outside behind the dumpster on a hot day. You know them well because they have a chronic alcohol use disorder. Those patients, you bring them in, you're treating them. You have to always be prepared to treat them for acute alcohol withdrawal also. Those patients are on psychotropic meds, cardiac meds. Okay, so we obviously don't have time for the cold stuff. So in summary, some benign conditions we talked about, right? Heat edema, heat rash, muscle cramping, those kind of things, generally treated with saline replacement and getting into a cool environment. You need to be more active with cooling them once they start to have a systemic temperature. Once they get over 104 with mental status changes, that's heat stroke, high risk for death and severe complications. You need to be aggressive with them. Always take a good medication history. I think we said that last week. Know what meds they're on because that can complicate their response to things. Some of those things that you would take with you if you're going to go on a trip and in a hot environment, you want to take electrolyte replacement tablets. You also want to take some antidiarrheals, which we'll talk a little bit more when we talk about some of the infections that you see with travel. Electrolyte replacement. The thing for you to do if you're going to be exercising or hiking in a hot environment, just make sure you take an adequate fluid with you, carrying the fluid with you. I see a bunch of people got water bottles here. You should be hydrating yourself well. And again, you don't have a thirst drive until you're about 5% dehydrated. So that's late in the course of this. All right. Any questions on heat-related problems? All right, good. And remember, acclimatization. If you guys have visitors coming here to see you, realize they're going to be sweating if they're coming from not a hot environment, and it takes about 10 to 14 days for that acclimatization. Will you all probably experienced that when you came here if you came from a cooler environment. Okay, I hope you took away 1 or 2 pearls from that. Enjoy the rest of your day. And then tomorrow, got a couple of different things. Maybe we'll do some envenomation tomorrow. Envenomation from different things that you may be exposed to in different environments. Okay, thank you very much. You're too kind.